We shall go on to our first speaker, Dr. SUJITHRA, who again is a clinical additional professor of the Department of Ophthalmology from Amrita Institute of Medical Sciences, Kochi, and she is going to take us on to a very important topic, traumatic optic neuropathy. On to you, Dr. SUJITHRA. Can you share your screen?
Yes, ma'am. Okay, is my slide visible and am I audible?
Yeah, both.
Yes. Okay. Thank you. Good evening. Thank you, Chitra ma'am, for this opportunity. And I'm moving on to my topic, traumatic optic neuropathy. And it is a very difficult topic. And I'll go through 2-3 cases which I come across, then to the topic. Okay, first case, it's a 28-year-old male. He presented with loss of vision in right eye following RTA. There was vision at presentation was doubtful PL, and there was proptosis and restriction of all ocular movements, and his left eye was normal, and CT scan showed fracture of orbital wall, that is medial wall, lateral wall, and floor, and there was hematoma in the orbit and hemosinus on the right side. So IV methylprednisolone was given for 3 days, then oral steroid was started, and immediately we did cannulisis and evacuation of orbital blood, and his proptosis improved, but vision did not improve. And the second case is a 57-year-old male presented with decrease in vision in right eye following RTA. He reported 4 days after RTA, and his vision at presentation was 6/60, and there was RAPD, color vision was defective, left eye was normal, fundus also was normal, and in CT scan report was normal. There was no intracranial bleeding, but since there was RAPD and vision decrease in vision, we did MDCT with 1 mm cut, which showed fracture of lateral bolus phenol sinus with mild indentation of the optic nerve. And IV methylprednisolone was given, and for 5 days, then he was started on oral steroids on tapering dose. His vision improved, and visual field also improved. Color vision was partially defective. And 27-year-old lady presented with loss of vision in right eye, and there was RAPD, and CT scan showed right orbit and orbit fracture and hemosinus, and she was given intravenous methylprednisolone, and orbital decompression was done, and her vision improved, and there was improvement in visual field also that we can see in this picture. So when I analyzed retrospectively the cases which I saw in our department, the younger age group is more commonly affected, and males are more commonly affected. 91% of the patients are males, and our most common cause is road traffic accident, and indirect traumatic optic neuropathy is more common when compared to direct injury. And most of the cases are associated with orbital fractures, and lateral wall fracture is more commonly affected associated with optic nerve injury. And coming to treatment part, 24 patients received intravenous steroid therapy, and 5 patients received surgical treatment, and 5 patients were managed conservatively. And we saw that patients presented with poor visual acuity had poor final visual outcome, and lateral wall fracture was the most common fracture associated with indirect traumatic optic neuropathy with a poor visual outcome. Coming to the topic, traumatic optic neuropathy, there are 2 mechanisms, direct and indirect. In indirect traumatic optic neuropathy is the most common form of traumatic optic neuropathy. The blunt head trauma, usually to the forehead, produces a deceleration injury and which leads to sharing of the nutrient bile vessels, leading to optic nerve injury. Another mechanism is force of impact on the forehead is propagated and focused at the orbital apex in the area of optic canal as a shock wave, producing optic nerve damage. Direct optic nerve injury can occur from a compression by a bony fragment, or it can occur due to orbital compartment syndrome due to active hemorrhage in the orbit. It is an ophthalmic emergency which requires immediate management. Direct optic nerve injury can also occur due to penetrating injury or transection of optic nerve fibers or compression from hemorrhage, edema, or impingement on the nerve by a foreign body. Optic nerve head avulsion is also a rare injury. It presents with profound visual loss. A rare cause of direct optic nerve injury is optic nerve sheath hematoma. Here the presentation is there is progressive visual loss. Initially, it decreases slowly. So this is a classical finding of optic nerve sheath hematoma. Coming to presenting features, most common symptom is vision loss or defective vision, depending on the severity of injury. Again, coming to clinical signs, most of the time we won't be able to record visual acuity since the patient is under trauma. Sometimes they may be not oriented or not conscious enough. We have to depend on our pupillary examination. So RAPD or sluggish pupillary reflex would be the key finding to suspect optic nerve injury. And also the history part and also the severity of injury, there being involvement of optic nerve. So we have to be very careful in assessing pupillary reflex here, because we won't be able to assess visual acuity, color vision like that. And in acute stage, the fundus examination also will be normal. And coming to evaluation part, so whenever we see a head trauma, we should do imaging CT scan. That too we have to do if we suspect optic nerve injury or optic canal involvement, we have to do MDCT with 1 mm cut to look for any small fracture imaging on optic nerve. And if we suspect hematoma, it is better to include MRI also. If there is no contraindication for MRI, like any metallic foreign bodies. Otherwise, it is better to do CT and MRI combined. Coming to treatment part of it, still there is no definite treatment for traumatic optic nerve injury. There are various studies which supports giving intravenous methylprednisolone. Some studies are against, and some studies they say that the outcome is good even with treatment or without treatment. But one definite evidence is if there is severe brain injury, we should not give intravenous methylprednisolone, as it causes the mortality rate is more in patients who received intravenous methylprednisolone when there is severe brain injury. Due to paucity of time, I am going very fast. And this orbital compartment syndrome is a definite indication for urgent surgical decompression. If there is severe hemorrhage with a tight orbit, we should do immediately, we should do cambolysis and release the orbital pressure and evacuate the blood clot. That will save vision. That's all. Thank you. And to conclude, the prevention is better. So we have to create awareness about safe driving so that we can avoid traumatic optic injury, head injury, because most of these people involved here are young males. Thank you. Thank you so much. Thank you, ARC, for giving this opportunity. Thank you, Chitra.
Thank you. Thank you for a very crisp and very nice way of taking it on with examples. And it was a very gripping talk. Thanks a lot. I just thought I'll take a question or two, and Dr. Shreya would also take. And Mr. Sunil, you will have to keep a watch on the time. Of course, this talk was very much within time. Please, Mr. Sunil, be connected so that 7th minute you give us a warning.
Sure.
And the one question is, how rarely or how often would any of you think of doing an optic canal decompression? Because I think it is something which can be done if it is within 24 hours of the injury, right?
Yes, yes. Nowadays, we have endoscopic assisted surgery we can do. If the presenting visual acuity is better, then outcome also would be better. And if the presenting visual acuity is no PL, then again the chances of visual recovery is less. Still, we can do optic canal decompression if there is bone fragments or hematoma in the optic nerve.
Yeah,
There is one patient I showed where there was improvement in visual acuity. In another patient, though there is bone fragment impinging and there is blood collection in the sphenoid sinus and the medial wall of sphenoid sinus impinging on the optic nerve, he improved with methylprednisolone alone. So still there is no definite way that this is the treatment.
Which kind of ocular trauma, Dr. Grover, when would you refer them to a neurosurgeon and not treat the eye as a first instance?
So, Chitra, foremost, there are very few indications for intervention because there are no multicentric large studies or controlled studies, of course, are even more difficult. There was an attempt at a multinational, multicentric study, which could not muster enough cases, so it was abandoned. That was about a decade ago. So there is no conclusive evidence to say that decompression fares better than IV pulse steroid therapy. And only if you have a definite bony fracture seen impinging on the optic nerve that you think of a decompression. Most of the times we are able to, if there is a sphenoid fracture which is causing it, we are able to get our ENT surgeons to work endoscopically to take care of that. Very rarely is a neurosurgical intervention needed. And an endoscopic navigation guided intervention can also be done through the orbital approach, which Kasturi has done a few and she's been happy with the results. But on the whole, the indications for surgical intervention remain very limited. And most often you would go by IV methylprednisolone, except if there is a compressive optic neuropathy, which Dr. Sujithra showed so well, where there is a clear-cut indication for decompression.
Dr. Shreya? Can you unmute yourself? You're muted.
Thank you, Dr. Chitra, for allowing me in this presentation. Most of my questions are already answered by Dr. Grover sir, but I would still ask Dr. Grover sir that what are the different surgical modalities would you prefer for different kinds of traumatic optic neuropathy, and exactly at what time would you like to intervene? As already some of the questions answered. Am I audible?
Yes,
Yes,
you
you
are.
are audible.
So if
Yeah.
you are to intervene, you have to intervene early as possible. And especially in cases where the visual acuity is poor, you would have a greater threshold for intervention. In others, you would probably go with IV methylprednisolone only. And those supra doses which were earlier talked about in spinal injuries have now been abandoned. Very, very high doses which were earlier being used in spinal injuries were also tried in orbital injuries. Those are almost given up now because of higher mortality. So intervention, if it is to be done, is either a transsphenoid approach if sphenoid bone is involved with the involvement of the ENT surgeon, endoscopic ENT surgeon. Sometimes a neurosurgeon, when you find that they cannot approach and it is a very close to the orbital apex. But at other times, you have a fragment on the medial side, which is impinging, and you can go in from the orbit as well. So all three approaches are possible, and depending on which bone is seen to be impinging on the optic nerve. But these will be very few cases. Most of them would be treated conservatively.
Thank you.
Thank you.
Okay. We shall now go on to our next speaker. Thanks a lot, Dr. Suchitra. Do stay with us and add to your thoughts.